All right, good afternoon. Thank you for attending. My name is Emad Ibrahim. I'm an associate professor of urology and neurosurgery, and I'm the director of the Fertility program at the Miami Project. And today's talk is going to be a little bit, it's fertility, inflammasome-related investigations and studies that have been done. And we will start first with how it started with spinal cord injury, and then we'll go through the other etiologies. So this is stats, and I'm sure most of the audience here will know about that. The only important stat here that we really should be concentrating on is that the majority are males, and most of the males are in their family starting age, so they're around 40s, in the early 40s, so they most of the time that they want to start a family. And which interestingly, there was like about half that were single at the time of injury, 45%. So it's important that these want to go into a relationship if they are not into one, and they want to see if they can have a family with that. The common causes are generally the same. It differs from one state to the other, but generally we have motor vehicle accidents and then falls. Violence with gunshot wounds would be the third cause, and then sports and others. This survey has been standing the years, so it's been done by Kim Anderson back in 2004, and it still applies, and most of the other surveys that are done follow the same pattern. And it was testing the importance, order of importance, the quality of life to men with SCI. And out of 681 respondents, arm and hand function came first in tetraplegics, and then sexual function was number one in paraplegics and number two in tetraplegics. So sexual function is important, and part of sexual function would go into the fertility part as well, because they are combined together. So fertility really, after spinal cord injury, does not affect females in a larger scale. They can get pregnant with no problems, but the issues come later in pregnancy with the heavy weight of the uterus, especially if they have autonomic dysreflexia, can trigger some autonomic dysreflexia, and also the bladder, pressure on the bladder can cause a lot of issues. And also late in the pregnancy, females do not feel the contractions, so that is the reason it's considered a high-risk pregnancy, and they go into preterm labor very frequently, so they are admitted early to be monitored. And there are various reports if it's C-section or vaginal delivery, and the C-section is not recommended. It depends on the case. On the contrary, with males, over 95% cannot father children with natural means. And the reasons for that are three major complications after spinal cord injury. So the first one is erectile dysfunction, and that is managed most of the time same as able-bodied men that have ED. We start with the normal oral medications, the PDE5 inhibitors. We try different ones. Then if it doesn't work, then there's also the option of intracavernosal injections or vacuum erection devices. If that doesn't work, then the last resort most of the time would be a penile prosthesis. The different considerations for each one of them depending on hand dexterity, depending on also other issues regarding if there's a partner or no partner, if the partner can help or no. So these are the considerations that are different than able-bodied, but technically the same. Ejaculatory dysfunction is managed by two standard procedures that we do. One of them is penile vibratory stimulation, and the other one is electroejaculation. It's been studied frequently, and the Miami Project considered one of the pioneers in advancing these procedures and in even educating other providers about that. And if we are able to overcome these two obstacles, that we're facing a major issue, which is the abnormal semen quality, and that's what we're going to talk about in details. I'm just going to go quickly through the methods for sperm retrieval. So in order for us to get semen, we can do PVS, the penile vibratory stimulation, and it's safe, and it's successful in about 86% of the cases, depending on the level of injury. So if it's T10 or rostral, then it's about 85% success. It's inexpensive, and one of the good things about it is it can be used by the patient at home if the patient is very well trained and controlled if they have autonomic dysreflexia. It yields the most important parameter that we look for, which is the total motile sperm in an ejaculate. So it yields the highest total motile sperm, and it's 15% success if the level of injury is caudal to T10. Also, we have to monitor autonomic dysreflexia, as we discussed earlier. If it doesn't work, then EAJ would be the next option, and we say nearly 100% success rate. The only reason is because if the patient had some sensation in the sacral area, then we need to take them to the OR. And if that's the case, then we have 100% success, but some of them, because of the logistics, insurances, and things like that, so we don't do that. It's the cost is similar. CPT code is basically the same for that, but the startup equipment is a little bit on the higher end because the vibrator costs about $900, but the startup equipment, if you want to have an EAJ machine and probes, goes beyond the $25K. And also it requires specialized training. So PVS anybody can do. Even the patient themselves. Electroejaculation has to be done by a trained physician. Risk of AD is the same, and it's of course more invasive, so it's not preferred, but if that's the only option, that it will work. Prostate massage, there's not really a lot of data about prostate massage, only few studies. Some people would claim that it results in a good sperm retrieval. But there are inconsistent reports, and also the risk of AD was not really talked about extensively, which could be the case as well. These are semen, and when we come to sperm retrieval, then there's surgical sperm retrieval through different types, either getting from the testis or from the epididymis. Does not require really specialized equipment, and the risk is a little bit less for AD, not from totally abolished, but there is a little bit risk. It's higher cost, of course, because it has to be done by a urologist, and it yields the lowest total motile sperm count. That means that the couple are committed to do the most expensive assisted reproductive technology technique, which is the IVF-ICSI. If we look at the semen of men with paraconjury, if we're able to get that through PVS or EAJ, some of them will look similar to what we see here, brown color, and this is in about 30% of cases, and this brown color been studied in few reports and did not show that it changes the characteristics of the sperm quality, but the color is just different. And also when you look under the microscope, you're going to see a lot of these cells under the microscope. And these were like kind of interesting for investigators to see what are these cells, but the parameters that are crucial for us to find out what is different between the semen and sperm quality from men with SCI and able-bodied that are considered normal based on the WHO criteria. So as you can see here, there is no change in the number of sperm that is produced. The count is normal, no issues with that. The issues come with these two important parameters. The motility, as you can see, a huge difference in the motility, and also the viability, which is the number of sperm that are alive. So it could be moving but alive, and that could be not moving. So that's the parameter here that is important. And just to give you just an idea about what we consider normal, so if it's around 40% of the sperm are swimming in the specimen, that's considered normal based on the WHO criteria. In men with spinal cord injury, it's usually less than 30, 20, and sometimes we have in the single digits. So that's a crucial element because that makes the total mortal sperm count that we talked about earlier very, very low, and that commits the patient also to the same procedures, which is the IVF. And then checking here, I'm just going to give you an idea about the difference between when we talked about the motilities. As you can see here, this is the motility in a controlled subject. So sperm are swimming, happy, free. Most of them are, so that's a good example of that. But when it comes to SCI, you can see on the other picture over there, there are very, very few sperm that are swimming. The rest are clumped together. So the numbers are okay, but the swimmers are very, very lower than percentage-wise than in the controls. And that's the whole issue that we need to address, and that's what we're trying to do through the years. People thought that maybe because men with spinal cord injury are on wheelchairs and then the issues with the lifestyle, that might be causing this. So because of the neurogenic bladder and bladder management, people thought that that might be the cause. It's been proven that it's not. Then in multiple studies, in a wheelchair, scroll hyperthermia, higher temperatures that can cause damage to the testis. We've done a study, did not show any difference. And actually in that study, there were 10 men that are walking with crutches, not on wheelchairs, but the sperm quality was still deteriorated, same as people on wheelchair. Maybe because they don't ejaculate that frequently. Many studies have been done having patients ejaculate multiple times even in the same day. Picture stays the same, it does not change. Maybe because we can do it, people can masturbate, people can, few, like maybe 5 to 7% can masturbate, others that we do PVS or EAJ. The quality is different, but it's still below the normal parameters. Years post-injury doesn't change. We have patients that have been studied, and we have 2 studies, one longitudinal, one transsectional. We looked at the patients, there are no changes within years after injury, and I have patients that have been seen for 20 years. The quality is the same unless a dramatic pathological event happened, but if they are healthy and normal, nothing happens to them, the same quality. So that means that lifestyle is not the issue. So then where is the issue then? We think that it's coming from the accessory gland itself. We have seminal vesicles, we have prostate. These might be contributing to the element that is there. And these are the glands that secrete the fluid that accompanies the sperm. So the sperm is produced by the testes, go to the epididymis, and then mixed with fluid from the seminal vesicles and the prostate and some other smaller glands. That's what's causing this. We thought about that. So that was studied to see what are these cells. And it happens that we found that mostly are activated T cells, activated T lymphocytes. And when cytokines were examined in the seminal plasma, which is the fluid that is with the semen, we found that there are very higher concentrations of IL-1 beta, TNF alpha, and IL-6. In a study that was done in a cup, so it's an in vitro study, that monoclonal antibodies were added to each of these cytokines to see if it improves motility, and we see that there are improvements than the one with not treated. But the most effective one was when they combine the 3 together. Also another study that was done with receptor blockers, and because you can see it's the same picture. So how can we get a treatment that would combine the effects of blocking all the cytokines or these cytokines together. That's when we thought about something that might be helpful in that, going upstream. That's when the inflammasome complex got involved. And of course, thanks to the team here, Dr. Dietrich, Dr. Keen, and Dr. Vakari, we were able to join efforts and try to find, for the first time ever, is the inflammasome involved in this situation or no? Simply, I'm not going to go into the details. I'm still a clinician, not a basic scientist, so I'm going to just make a simple diagram. I'm not offending anybody here from the big team. So it's technically a complex that has a sensor protein, an adapter protein, which is the ASC, and a procaspase. When triggers, either PAMs or DAMs or other triggers, would activate this complex, it changes into caspase 1, which in turn matures the pro-IL-1 beta and IL-18 into the active form IL-1 beta and IL-18, and this results to the remaining of the cascades of the cytokines that we talked about. So we studied semen and sperm in men with spinal cord injury to see if actually these inflammasome components are present in there. And as you can see in this picture, there is a huge difference between controls and SCI when it comes to caspase 1, ASC, and the pannexin 1 channel that we're going to talk about in the next slide. As you can see here with the Western blots, it's very clear. And also, we did an immunocytochemistry, and as you can see here, see this band? This is ASC and SCI. And in the controls, there's nothing. And then when it comes to caspase 1, the mid piece here has these signals, and it's not in the control. And this was the first report ever to talk about inflammasome in sperm in general, and of course in sperm with men with spinal cord injury. And there was a good correlation between caspase 1 and ASC and the sperm motility that we talked about. So the higher the concentration of each one of them, we will have lower motility. So we thought about first, initially, getting anti-SC monoclonal antibody, and I think at that time it was a polyclonal antibody, that we can just add in a cup and see if it's gonna change the picture and improve the motility. And as you can see here, the motility improved on all the subjects. That was like a small study with 32. But what's interesting is the lower the motility, the better the improvement. So the group that had a 1 to 5% motility improved a lot better than the group from 6 to 40, which is still below the normal, improved. The normal category did not improve, or did not, there's no statistically different changes, which makes sense. So we're trying to target the ones with the low motility. These are the ones that should have a higher concentration of the inflammasome components. But this was in a cup. What we wanted to do is try to find something that would help the patients take the medication and improve it without putting some investigational chemicals that could not be used. So if I put the anti-ASC in a cup and I see improvement in the motility, I cannot take that to the IVF center and tell them, please use that sperm in an IVF procedure because it's not safe. We don't know the safety parameters around it. So we thought about maybe there's something that would help. So that's when the pannexin 1 channel came into the picture. It's a cell wall channel that helps to activate the inflammasome complex and cause the cascades that we talked about. And luckily enough, probenecid is it's a drug that has been studied for many years and used clinically for so many years for treating gout, but it's not used anymore. It's available still in the market. It's very well studied and been used for patients for many years, so it is safe, and at the same time, it blocks the pannexin 1 channel. So we did a pilot study with men with spinal cord injury. We gave them probenecid by mouth for 4 weeks, which is the simple dose that we used in gout, and we did an analysis of their semen before, right after treatment, and then another 4 weeks later as a follow-up study. Interestingly, it was very well tolerated, and sperm motility improved. in all the subjects, as you can see here, even after follow-up, it's still improved, maybe not statistically significant, but improved. But remember, this is a pilot study and we only have 18 patients. But what's important is this category. So when we categorize sperm, we're looking at sperm that is moving, but we differentiate between the slowly moving ones, the vibrating ones that are not going progressively forward, and then the rapid linear, which is the progressively forward them. And that was the one that showed the highest improvement, and that's important also for any insemination procedure that we want to use that specimen in. And we did actually, with a group in Brazil, some studies on proteomics for shotgun proteomics analysis for the specimens that were taken from patients before probenecid and after probenecid. And we found that there were 17 proteins that are downregulated and 6 upregulated after treatment. And there was higher levels of some components and some proteins that are related to the innate immunity, which means that giving the treatment would lower this proteins, and that means that lower the immune response and increase the sperm motility. It's just a hypothesis, but that was shown in this study. So what we did is we submitted a grant to the US Department of Defense to see if we can study this probenecid in a bigger scale. So we actually were awarded a 40-year grant from the Department of Defense to do a double-blinded placebo-controlled trial, and that's done in collaboration between Urology and the Miami Project. What are the specific aims for that? We want to see if we give this medication for 90 days, and the reason we have 90 days is because the spermatogenesis cycle, which is the cycle that sperm is produced, new sperm is produced in a male, takes about 90 days. So we wanted to cover all the spermatogenesis cycle, because if you remember from the first study, we only give it for a month, so it might fall in the middle that we could not get new sperm. So this we're giving it 90 days. We're checking the parameters that we talked about, the total motile sperm counts and also the motility. We're measuring baseline, mid-treatment, and after. And then also, we want to test the DNA integrity of the sperm. So we want to make sure that this medication is safe. So we do DNA analysis of the sperm cells before the treatment, and then we'll also check after the treatment to see maybe, because when we did multiple studies and other did studies before, that the DNA integrity of sperm in menospinal cord injury is really abnormal. It's higher than what it's supposed to be. And we want to see if this treatment, even it does not further damage it or maybe improve it. And we're hoping that will improve the DNA damage. And also, we are going to study before and after the inflammasome components and also the all cytokines that we talked about before. We want to make sure that it's safe, so we're doing all kind of safety profiles, we're doing all the analysis, and we're doing reports, and we're checking on the patients regularly. And the most important thing about this trial, as we mentioned, it's a double-blinded placebo control, so the study team don't know what medication it is, the patient doesn't know what medication it is, and also other, like the analysis, the people that do the analysis for this study do not know what is the medication the patient is treating. So it's a randomized 1:1:1. Target is 30 per arm. One arm will take the full dose of 500 milligrams twice a day. 30 will take the 250, which is half the dose, and then 30 will take a placebo controlled medication that has nothing. It's only fiber pill. They're all done in a way that the pills look the same, feel the same, weigh the same, so that there's not, make sure that we want to make sure that it does not feel this one heavier than the other, so people might think that that's a placebo. And then we will do all the measurements that we talked about after that. Also, right now, we are trying to see if there are other medications that can be used, investigational medications that can be used. and funding through the MIMER project, the pilot awards, we are working with Dr. Vakari on trying to study the inflammasome in rodent models. So we're going to have a rat, and we're trying to see if the inflammasome inhibitor IC100, if it administered systemically to these rats, if it improves the quality, and we're going to get sperm from before, and we'll try to get from the sham animals, and we get sperm after that, and we'll see if there is any improvement or no. And we had that, these are the aims that we're trying to accomplish using this, and we're hoping that this, because this IC100 can be developed into a actual drug, and we can use that as a novel medication to improve that. So we're starting with the animal study, and we're hoping to advance that to see good results out of it. And we just have preliminary data showed what we talked about before. We did not administer the medication yet, but we see affects also the viability. Morphology is also lower, the motility is lower, concentration, but that's because it's a very low number. And the caspase 1, we've seen that it's also different from SCI to the sham animals. We try to see, that's going to take us to the second part of the talk, where we talk about inflammasome, and it's really, is it only in men with spinal cord injury and a fertility issue, or it's in other fertility etiologies and causes? So we did a small study here through the summer program. One of our students did that study, where we got samples from the fertility clinic that people are, so these patients are visiting the fertility clinic for fertility issues, and they give a semen sample. So we use that sample to analyze all the inflammasome components and also the cytokines that we talked about. And we subcategorized these patients into, one group had low sperm motility, so it's less than the 40%, but with a normal sperm concentration. Oligo, where people had low sperm concentration and normal sperm motility, and then one that has the combined, they have low motility and low sperm concentration. We took also SCI as technically our positive control, and then we got healthy normal spermic men as a normal control. And as you can see here, we looked at the caspase 1, IL-beta and IL-18 through all the groups, and there is a difference, as you can see here, but the most important difference that we've seen are in this group, where they have both low motility and low concentration. This is just data. The only issue with this study is that we don't have, at that time, we didn't have the diagnosis for these patients, so we can't categorize them. What we're trying to do now is to get more samples with accurate diagnosis from their charts in order for us to categorize them, not based on the parameters, but based on their diagnosis. So if they have varicocele, if they have azoospermia, if they have other things, and that's what we're going to talk about in the few slides after that, that people started getting the ideas from our publications, and they started to take it into different routes, which is great. So we'll start with the varicocele, because this is one of the most common causes of infertility in men. So it's basically, as you see here, this is the normal campaniform plexus, which is the normal spermatic vein configuration. And this is what happens with varicocele. It becomes very thick and tortuous, and that causes a lot of damage to the sperm quality, because it causes like overheating, technically because of the stagnation of blood in these veins, and it also causes some effects on the sperm integrity as well. So it's contributing to a major bulk of the fertility patients that we see. And this, so we have animal studies and we have human studies. Yeah.
Is that condition you described
No. It actually, most of the patients that we diagnosed are teenagers with the varicocele.
So what's the pathogenesis of that vascular?
It's some issues with so each vein should have the valve that would prevent the blood from going back in there. And there's valvular issue. It could be something genetic, and it's very, very common. So it affects like 30 to 40% of men. So it's not a rare condition. Sometimes it does not affect the sperm quality. So what we do clinically is when we have patients, because sometimes when it's very clinically clear without any ultrasound, so sometimes it's clear, so sometimes even in medical school, we try to learn how it is, so we call it the bag of worms. So it's like there's a lot of stuff in the scrotum that the patient would feel, especially teenagers, so they would come and see us. The first thing we do is do a semen analysis. If the semen analysis is normal, we follow them every year to make sure that it does not deteriorate. If it's affected, automatically we do the surgery, we do a varicocele surgery, and then we follow up after that to make sure. And most of the time, it improves the quality, but sometimes the damage is so bad that we recommend that we sperm bank before we do the surgery and continues that just in case sometimes it deteriorates to the point that is either extremely low numbers or even no sperm. No, there's just no difference. There's no difference, it's the same. So it's like the general population, same percentages, yeah. So in the animal studies, so one of the animal studies that was done, they did a varicocele-induced rats, and they looked at the testicular tissues, and they found higher concentrations of the NLRP3, ASC, and caspase-1. And then when you give 30 days of an anti-inflammatory, antioxidant medication, they saw a drop in these concentrations, and it was dose-dependent. So that was one of the studies that showed, okay, maybe this inflammasome can, if we manage it, we can improve that. And also there are other studies that are done using the PA, selenium, and PDRN, and that showed that the downregulation of these components this was done also in animals, and its inflammasome complex should play a critical role in that. There are two human studies, and I put them next to each other because there's one important difference here. So these were checking the inflammasome components in varicocele patients, and there was an increase in them. But what you can see from the study here is that the ASC is not really dramatically increased in this one, while it's shown here upregulated. And the reason for this is because this study is done by Camargo in Brazil, was done on varicocele patients that were regardless of their fertility status. So the patient was diagnosed with just varicocele. And remember, we talked about sometimes you have varicocele and you have normal sperm parameters. So this was done, so that's why we think that the ASC was not upregulated in this one, because some of the pool in there were men that had normal parameters, but in this study, they were only infertile males with varicocele. I'm sorry. So also as you can see here, and this is also important, so this is the same study by Camargo, and when men did varicocele repair, there is a drop in the inflammasome and the cytokines after 6 months. So this is crucial and important, as you can see, and there was an increase in the sperm morphology. Morphology is basically looking under the microscope and see what the sperm looks like, and there was an improvement in that, and that's also an important category. Another etiology that has been studied, which is obesity, And we've been studied multiple times in different pathways that obesity would cause male infertility. Some of it is because of the DNA methylation, some of the cytokines that are present, insulin resistance. Obesity would really work on the axis that can produce the hormones that are important for sperm production, the FSH and LH, and that's also working on, and leptin was part of it. And it's been studied that and shown that in an animal study that giving high-fat diet would really increase the inflammasome components, and when you reverse it with resveratrol, then we'll have lowered that, and it's also dose dependent. And what's actually interesting when it comes to obesity, and we in the clinic, we actually tried when the first medications came out to treat obesity, and then people were starting to use that for weight loss. So we studied them, and we found that actually sperm quality improved, but we did not really, it's like it was a short study, and sometimes the patients do not continue taking the medication, so we did not see a continuous effect, but it actually improved weight loss and sperm quality as well. Also, inflammasome has been seen in studies that would check the infection in patients. So, and then one of the studies with the orchitis, where it was like E. coli-induced orchitis, and in the Leydig cells, which is part of the cells in the testis, we've seen increased levels of the cytokines and on the inflammasome components. Another study also with lipopolysaccharide-induced inflammation in mice, caused epididymitis, which is inflammation of the epididymis, which is the part where the sperm goes from the testis, then travels through the tract, and also they've seen increase. So as I was saying, there's people took the inflammasome that we studied earlier, and then they using it in multiple areas. The last part of my talk is going to be, this is very important because we see a lot of patients with what we call azoospermia. Azoospermia means no sperm. So you get semen, a good fluid, but there's no sperm in there. And there are two types of azoospermia that are important. There's obstructive azoospermia, so anyway in the tract between the testis epididymis to the outside where they get the ejaculation, there might be some obstruction, and it's a known etiology, we know what it is, so it's manageable in some of the cases, and in worst case scenario, we can get the sperm from the testis. One of them is like cystic fibrosis, where you actually don't have a vas deferens on both sides. So it's called bilateral absence of the vas deferens, and that's why when we do semen, we don't see sperm, but the sperm is in the testis and it's produced normally. So that's managed in that way. The one that is really important is the non-obstructive azoospermia. So the tract is intact, everything is intact, but there's no sperm production. So it's a production issue, not a transport issue. And in one of the studies that was done here, they studied patients with azoospermia, 24 patients with azoospermia, that were going to perform the microsurgical testicular sperm extraction from them. So it was done under the microscope. And they tried to study some of the elements, and they looked, and they found that they studied the serum and the semen to see if there's a difference. And they found that the seminal plasma, which is the semen, I1 beta and NLRP3 were significantly higher than serum, the blood. Also, they studied the total oxidant level, and they did not differ significantly, but the total antioxidant was significantly lower in semen than in serum, and the other way around when we did the oxidative stress index, which is a calculation of both. So there is some elements here that inflammasome is also involved. And this was another study that was done, and it showed there's overexpression of all the genes, and it was higher. So when we say NOA positive and NOA negative here, that means that these patients have non-obstructive azoospermia, and the positive ones are the ones that they found sperm when they did the surgery, and the negative ones are the ones that they did not find sperm. So the major difference that they saw was the NRP3, IL-18, and even AIM2 gene was upregulated and significantly higher in the non-obstructive azoospermia group compared to the obstructive one, which makes sense because it's a production issue. And they also found the levels were significantly higher in both the positive and negative compared to the obstructive azoospermia. Basically, we want to emphasize that men with spinal cord injury they are unique in their infertility categorization. They're different. And the semen quality is impaired, and we think that the seminoplasma is the toxic elements in there that's causing this. We've shown that the inflammasome can actually be identified, and when it's targeted, it can improve fertility, and we're still undergoing. And then inflammasome is expanding into other male fertility etiologies, such as varicocele, obesity, infections, and even azoospermia. This is my team. We have Odaro, our clinical coordinator. We have Mika, we have Ore. They all helped me in this big study with the Department of Defense and also with the animal study. And with that, I would like to thank you all for listening and open for any questions. And these are my contact information. People are interested in social media is there, and my email is there. Thank you.
Great talk. Thank you very much.
Thank you.
Yeah, we didn't pay you anything to talk about inflammasome. For your
Yeah.
clinical study, did you consider a crossover design where you would give the placebo pill and the inhibitor pill interchangeably in the same individual?
It's not in the study. I thought about it, but the actual way that the clinical trials would work better is to have the patients first blinded, which is this part of the study. And then when we unblind, we will give the patients who are on the placebo, or if the lower dose did not work enough, then we give them the full dose and see if there's any improvement or no. That depends on the outcomes after we unblind the study. But yes, definitely, yeah. I actually give it anecdotally now based on the preliminary data that we published for patients who don't want to be on the study and they have issues with the motility, and I give it to them, and I've seen few that are improving, and I'm waiting for some pregnancy data so that I actually can publish that as case reports. Yes.
So have you compared the inhibition by connexin versus IC100 or ABB? Which one, for your estimation, works better? There's also a follow-up.
So we haven't tested the IC100 in the actual human samples. We're trying to do that in the animal model, but it would be a good idea to maybe use the anti-ASC, the polyclonal one, and do the IC100, and then we'll see. For the probenecid, it's going to be tough to do it in a cup because it's a powder, and it might affect the consistency of the specimen and do that. So, and we have the advantage of doing it orally safe. So that's why I might study the effects from the same sample. We give oral medication and get the sample and study the effects, and then would do the same sample, add anti-ASC, the regular polyclonal, and then IC100. We can do that, definitely. It's not a bad idea.
So the other thing about the obesity treatment, what drugs did you
We tested Ozempic at that time.
so that's GLP-1?
Yeah, GLP-1, yes.
The big thing in the inflammasome field now is coupling that with GLP-1s, and there seems to be an
Yeah.
So I was wondering if you had try or try something.
We can definitely. I'm open for any suggestions to try things that are different, and especially with the GLP-1s, they are like cruising now, and everybody loves them, and everybody wants to use them. So might as well if we just combine some studies and we submit a grant or something, that would be great. Yeah.
You have showed that the patients with very HCL, regardless of their fertility status or the semen quality, showing high inflammasomes. So how this be correlated to the semen quality?
Yeah.
The second question is, you showed that patients after the varicocele patients after the varicosectomy,
Yeah.
they show it regardless. Despite having a difference in the characteristics of the semen analysis regarding the concentration of the volume, but the slide showed that there is no functional changes in the sperm. I guess you mean progressive motility or stuff like that. So how could this be explained? The relation between the varicocele and
So let me put something clinically important. So when we see a patient with varicocele that has no damage and no effects on the sperm quality, we don't do surgery. So the ones who had the surgeries are the ones who had lower parameters to begin with. And these are the ones that we aim to see improvement in the sperm parameters. That is separate than seeing changes in the inflammasome and the cytokine profile. So these are two separate things. You might see changes in the profile, but you don't see changes clinically on the sperm parameters. Yeah. Yes.
I think oral daily Prevenacid has been prescribed up to like 2 or maybe 3,000 milligrams per day. Is that the case? Like, why not?
I mean, yeah, so you're gonna, I understand that with gout, usually they used to do that. And then now it's not used for gout, it's used as a combination with any antibiotics that have poor absorption. But the problem with that, if you increase the dose, the patient will have more GI symptoms, because that's one of the main issues with Prevenacid. So that's why when we give it, we say take it with a lot of water and with food. If you jump that to over 1,000, so now we're giving 500 twice, which is 1,000 milligrams. Now you're talking about giving 1,000 twice a day. That's going to cause some GI issues, and I didn't want that to be part of like ruining a good chunk of patients. Because remember, with the SCI, patients take a lot of medications. So I don't want to exacerbate that, and then I don't know exactly if it's because of the medication or it's because of one of the other profiled medications that they're taking. So we want to make it on the safe side. That's the main reason. And one of the reasons also I gave the lower dose is because if it gives me the same effect, then might as well give lower dose and minimize the side effects. Yeah.
I guess a somewhat related question. So since you're testing a number of inhibitors now and you have a rat SCI paradigm, have you thought about doing pharmacokinetics of your drugs in the testes to look at helping in dose titration, dose interval, so that you know how much is getting in there?
So we're talking about the rat models or the humans?
Right.
Yeah, we will check the testes. I mean, right now we're just trying to see the preliminary data, and we'll see the changes in that. But definitely we want to expand this, and we're gonna have, if we have good data, we're gonna give a grant, and then we look at all these, of course, changes, if the changes are important. But that's an excellent suggestion, yeah.
Okay, so this is a good example of some of the things that the project tries to do in terms of improved quality of life, people with things like paralysis and other conditions. And an interesting story, I met the New York dentist 2 years ago, and that's where maybe fundraising and that's what 100 people come. So I'm sitting there, and someone taps me on the shoulder and goes, "Oh, people, if I can introduce myself." So it's a young man and his wife, must be in his 30s, 35, something like that. I said, "Nice to meet you. Why are you interested in being here tonight?" He goes, "Well, because I'm the result of the research being done in the fertility program in our project." It turned out that his father was one of the first STI men that actually went out under the fertility program. they retrieve the sperm and actually introduce them, and the wife actually had this
Yeah.
individual, this son, and they now have 2 children. So they say every day we get up and we kind of think about the project in terms of why I'm here today and have family now, because, and I think Chick Lynn and Nancy Brackett, for example, many years of the
Yeah.
following up with the research. It's just a really interesting story where we made a difference in so many
Oh,
ways.
definitely. And these families are very grateful. I mean, up till now, I get every Christmas like a card that was originally sent to Nancy Brackett, and then they continue sending to me like a thank you for, it's a family that they were able to have 3 children through the program. And they are like, the children now are like, some of them are even married and they have their own children. And they're still very grateful up till this minute. So it's very important, the quality of life issue, yeah. Thank you, appreciate it. Thank you so much.